Yeah, I'll just introduce this session series and briefly, Dr. Ashoojit, and then you take over. Yeah.
Please,
So
thank you.
yeah, so we these sessions which we have every month on Saturdays, like 2 Saturdays of every month we have. We call them exchanges in primary care (EPC). So basically, the aim is to create a platform where people working in primary care can come together and share their things, like things which they are working on, things they want to get feedback from people, or any learnings, or any new papers or new articles which have come up, anything which might be relevant from a primary care perspective. We invite people to come and share here. So, and it is a very informal platform, so it is not like a typical didactic session where people we can just chat around and discuss things as we present. And yeah, and it is an open space, so it is not necessary that anybody who has done something extraordinary only can share here. Like anybody who is in the early stages of a program, or anybody who is like confused and wants to get inputs, they can come and share. So today we have Dr. Ashoojit with us. She's from Bangalore. She's a community medicine doctor as well as a family physician. She has started a company called Sarv Aveksha, right? If I am pronouncing it rightly. Yeah. Okay. So that is in Bangalore, and it tries to make primary care accessible to people at the doorstep of the people. And she has been doing some interesting work for patients with dementia. I think dementia is something which is already appearing in tribal areas and rural areas also. And in the coming years, I think it will become a major issue. So it will be good. We thought that it will be good to listen to her and learn from her experiences. So thank you, Dr. Ashujit, for agreeing to share here. And I think I can hand it over to you now. And please take ahead. Take it. Please take over the presentation. Yeah.
Thank you, Sham, for the introduction. Yeah. So, like Sham said, that we provide a Sarv Aveksha, which Aveksha means care, and Sarva is for everyone. So, caring for everyone is what we do. And we exclusively provide actually home based primary care, that is going home and seeing people. And it so happens that about 95% of the population we cater to is elderly who find it difficult or challenging to visit a clinic or a hospital. So they prefer being seen at home. Now, in our practice, okay, right now, I think we have almost about 80 patients, active patients right now, in which I would say about 15% might be people with dementia. Yeah. So might not sound very alarming, but then it is quite alarming that 15% is a huge population where people are struggling. It's a person who struggles initially, and then it's the family which struggles a lot. So I will, of course, lay out I have a few slides which goes by, what are the causes of dementia, what is dementia, what is the burden globally and in India, and what are the causes, what are the reversible causes and irreversible causes for dementia, how we can prevent dementia, and how we as a team approach dementia at a home. Yeah. How do we manage people? Now, people means the person with dementia and the family as well. Yeah. So let me start with giving you just a outline of what is the burden of dementia right now. I'm sorry, I am unable to play my, yeah. So like I said, we'll just look at the burden of dementia and what are the factors, risk factors and causes. How do we actually diagnose or assess dementia? What is the level of dementia? That is the tools for diagnosis, and then management. So our learning has also been that last year, me and my colleague and friend, Dr. Praneet, we both attended a 6 months course uh, on dementia by the International Dementia Academy for South Asia. Yeah, this was an online session for 6 months we had, which was the academy is based in Ireland, but it was more catering to the South Asia. So some of the statistics and some of the learnings are from that as well, which we apply to our day-to-day practice. Yeah. And so this is the burden of dementia globally and in India. So in India, um, the which is the longitudinal aging study, which was done from 2018 to 2020, which said about 1.37 billion is the total population, of which about 8.8 million of the people who are above 60 years had dementia, which means about 1 in 13.5% have dementia. And females are known to have the prevalence is more among the female than men. It's about 9 to 5.8. And surprisingly, this was also surprising for us as well, that rural has more number of people with dementia as compared to urban. It's 8 and 8.4 and 5.3 is the urban. Now, dementia is growing exponentially for the reason that the aging population is increasing. And as the age advances, we also have problems, other problems with longevity, and dementia is one of the problem. And we say by 2050, 1 in 28% in India would have dementia. Now, this doesn't sound very alarming because it's at the moment 1 in 13.5, and it will be 1 in 28 in 2050. But what is alarming is that WHO says that this would be India would be the second largest country with the highest burden of dementia. Because the burden again doesn't mean just the people who are living with dementia, but it is a challenge for the family. And as we see that, our fertility rate is below the replacement rate now. So we are going to have more of people living long, but as well as we are not going to see younger population there. They are going to be lesser and lesser in number. And that will become a burden. The WHO says that people, there would be people struggling with dementia who don't have caregivers. The younger population is going to be lesser and lesser. So that's the burden. Globally, there are about 57 million people living with dementia. Every year, they say about 10 million people are added. And maximum number of people with dementia are from the low and middle income countries. So this entire what we had the session was in South Asia. So there were people from Bangladesh, Pakistan, India, and so the India has a very high number of people living with dementia as compared to the population with other countries. Yeah. Now, what is dementia? So dementia is a symptom where a person forgets, there is forgetfulness. And this is a picture which shows the trajectory of cognitive decline. After the age of 60, there is a slight cognitive decline if we do not uh, keep ourselves abreast, involving or indulging in newer learning, and the cognitive decline is noticed. Now, that is a little bit of cognitive decline is the normal aging. But when there is mild cognitive impairment or there is further decline in cognition, that is when it is called dementia. So in a aging decline, it kind of comes down and then it stays at that, there's no further decline. And this is what is the trajectory. But when it is dementia, it declines. It really declines because it's a progressive disorder. So it's a symptom and it's a progressive one. The next slide, can you go to? Yeah. So these are some of the causes I have listed down and the risk factors which are modifiable and non-modifiable. So among the causes, also these are modifiable and non-modifiable, which are all together. You have the genetic cause, which is the ApoE gene, and ApoE E3 is seen more among the Indians. Then you have the environmental factors. Environmental factors, you have, pollution. We were just talking about pollution giving us the respiratory infection, but pollution can also cause a cognitive decline. Pollution, infections like which can lead to cognitive decline, meningitis. Then you have like in HIV, we have something called PML, where there's a cognitive decline, atrophy of the brain. Then you have chemicals which are found in the water, food, all that which causes a cognitive decline. Injuries, very common, especially it was quite, surprising when we had attended this session, the International Dementia Academy. They showed pictures of India where people are driving 3 on a two-wheeler without a helmet. And a mild concussion in your younger days can also can be a cause for dementia in the later age. So injuries, head injuries, seizures are people having seizures and maybe under treatment but not well controlled can cause a cognitive decline later. Education, because people who are educated or who are literate, they are learning newer things. They are reading, they are writing, they are into multitasking. So they are able to, their cognitive decline is much slower and they do not develop dementia as much as people. But then again, I don't know because we have had patients who are bankers or who are scientists and they have dementia. So I don't know how much that is valid here, but then, these learning things or knowing how to drive, how to do your banking. Now, of course, internet banking, but then all that going to a bank, writing your check, submitting, all that reduces the risk of dementia. Cultural, there is like because of elderly people having social isolation, loneliness. These are some of the cultural things which causes dementia. Economically, because affordability, accessibility to healthcare, again, delays the diagnosis, delays the on starting the management and thereby progressing the condition. Lifestyle. So dementia is also known as a lifestyle disorder. A poor diet, nutritionally imbalanced, where there is deficiency of vitamin B12, we say, all the B1, B6, all these are known to cause decline, cognitive decline. Then lack of physical exercise, lack of sleep, increased level of stress, depression, chronic depression. Even when a person is on medication but has a chronic depression for years together, the chances of having dementia later in life is very high. Technology, I was talking about that. Now we have AI coming in, chat GPT is there. You enter everything and it all gives you the answers. It gives you everything. So lesser and lesser use of our brains and thereby a decline. Hypertension, diabetes, these are some of the causes which can cause a CVA and thereby have a cognitive decline, like a stroke. Then vascular causes, again, a stroke, or they can be atherosclerosis and causing lesser, carotid atherosclerosis, causing less of blood supply to the brain. Risk factors, there are modifiable and non-modifiable. Again, all these causes which can be modified are, mostly lifestyle associated. You can alcohol, smoking, diet, exercise, all this are modifiable. Types of dementia, or what are the causes of dementia, and types of dementia are the something similar. Here, it's very important to know that Alzheimer's, a lot of people think Alzheimer is different and dementia is different. Alzheimer is dementia and is a type of dementia. And they say that about 60 to 70% of the cause for dementia is Alzheimer's. Then you have the vascular cause. You have other mixed causes, which are just a fewer number, but maximum is Alzheimer's. Going to the next slide. How do we identify dementia? So there are three things which need to be the signs and symptoms under three categories, which we say there's a cognitive, there's functional, and behavioral. So the cognitive, we discussed about cognitive, it's memory and recollection, concentration, all that is the cognitive. The functional is your daily living activities, ADL we have. These are the functional one. And the third is the behavioral and psychological, which is mood. There is a lot of aggression, agitation, hallucination, lack of sleep, being awake, talking to oneself. All these are some of the signs and symptoms in dementia. Going to the next slide. These are some of the tools I have enlisted, but what we normally do for cognitive, we use is the mini cog or the GP cog. Yeah. In the GP cog, you have a first sheet where you have certain assessment, like you have the recall, where you give 3 words and ask them to repeat. Or the mini cog has, the clock drawing a clock. You ask them to draw a clock and ask them to mark it as 10 minutes to 10 minutes to 11 or 10 minutes to 10. And we find that people do struggle. The shape of the clock, everything, people struggle when they have dementia. And recalling numbers or recalling, like you give them 3 objects and tell them to recall after a while, or give them an address and ask them to recall. Now, these things get a little difficult when you are in a rural area where people are not very well educated or are having difficulty in reading and writing, or they don't read and write at all. How do you assess? Especially the aging population in the rural areas might not be able to read and write. So you give them few words and ask them to repeat. Show them the pictures of animals or flowers or whatever are more common and ask them to identify. We also ask them to identify, like we keep a paper and a pen, and we touch the paper and say, can you give me the pen? Pass the pen to me. Yeah. So these are some of the cognitive assessment tools. We have the MOCA, that is the Montreal Cognitive Assessment Tool. You have the They told us that the ACE3 cognitive, that is Edinburgh's cognitive examination, is something which can be used in a rural area. But again, some of these do require some amount of reading and writing. So developing something, Nimhan said that they have, Vellore has developed something in different languages. But again, they all require some amount of reading and writing. So the best way would be, giving them 3 words to recall, giving them an address and asking them to recall, identifying certain pictures. These are some of the cognitive assessment. Then you have the functional, you have the basic activity living, and you have instrumental activity daily living. What is the difference is basic is, about having a bath, combing your hair, changing your clothes. Are they able to button up their clothes? Yeah. Um, these are some of the basic activity living. Then instrumental is like dry banking work. More of these finer works are the instrumental activity of the daily living. Telephone, making a call, looking for the number and making a call. Yeah. These are some of the instrumental of the activity of the daily living. Then behavioral and psychological actually don't have a tool as such, but you need to identify the signs and symptoms. So normally we find when we go to a patient's home, the family tells us that the patient has been behaving very weird, wakes up in the night, walks around. Uh, we recently had a patient where the son lives in Bahrain, and he keeps on calling us because he says he has fixed a camera. His mother lives with his aunt and uncle, but still, he has kept a camera to take care of her remotely. And she gets up in the middle of the night, goes and checks the door, and comes back and goes to bed again. On few occasions, she has opened the door and gone down. And she said that I have to go to the other house. My 3 children are waiting for me. She has only one son, but she said the 3 children are waiting for me. I have to take them to the school. You know, so these behavior and psychological things, the family tells us as to how the person has been behaving. We also need to identify what are the triggers. Now, like this lady walks down, opens the door, and the sister comes running from her room and in the middle of the night starts shouting at her, "Why are you opening the door? There's nobody outside. Why can't you go and sleep?" She loses her temper. And then it triggers that she gets annoyed, she starts shouting, and she's unable to sleep. So the behavior very much depends on those triggers. What are the triggers? We need to identify that. So that is identified only when you spend time and talk to the family to understand what are the trigger points. Going to the next slide.
Dr. Ashoojit, I had one query.
Yes, please.
Yeah, for the cognitive assessment, you said that we can check names of words. So, should those words be like recent words which we tell them, or like it will be from a remote
No,
memory?
random words,
Mm-hmm.
not from the recent memory. You can also ask them, because now I think television is available everywhere. So they might be watching the news. What is the latest news they watched? What did they watch
Mm-hmm.
on the TV? If
Mm-hmm.
they say it was a serial, you ask a little detail about the serial. Or if they say
Mm-hmm.
it's the news, then what was the news? And whether that was a relevant one, what they answered.
Mm-hmm.
Was it the news of today, or was it they randomly said there was a fire outbreak? You know,
Mm-hmm.
but
Mm-hmm.
ask them, where was the fire outbreak? Where did they
Mm-hmm.
see that? Yeah. So then
Okay.
you're able to, because
Yeah. So,
initially the patients are quite smart. You won't be able to make out. Sorry, I didn't get that. Somebody asked something.
no, I don't think so.
Okay.
Yeah.
Okay. So
Yeah.
initially people are quite smart because they know they are forgetting and they know how to evade those questions and answers. So they try to answer you in a manner which you are unable to make out whether it's right or wrong.
Mm-hmm. Okay.
So
So
this
in a
lady, like
rural set, yeah.
this lady, when we ask her, did you wake up in the night and open the door? Yeah, I opened because I went to check if there is someone outside. But in the middle of the night, nobody comes. If you tell her, she said, no, I heard somebody calling me. That's why I went. I'm not a fool to go and open the door. That's how she speaks.
Okay. So,
Sujit,
it,
Yes, sir.
may I come in? Yeah.
Yes, please.
Another very simple method of assessing cognitive function is to place some familiar objects like a hammer or a screwdriver, a flower,
Yeah.
or a fruit, some five or six, not too many. Keep five
Hmm.
or six objects on the table in
Hmm.
front of him or her and
Hmm.
ask her to sort of memorize it, take these away, and then ask them to recall those five objects after some time. These are familiar objects, they
Hmm.
must be. And that I found a very simple and effective way of cognitive assessment. I don't know whether that is the practical, it's very practical way of finding it. And
Yeah.
very early,
I agree.
early, the number of objects can be increased or decreased
Yes.
depending on,
Yes.
and that kind of assessing severity would be a very useful tool in a family medicine setup.
I agree. Because this kind of tool actually, sir, they had used it um, for a study which was done in TDU. TDU is a transdisciplinary university here in Bangalore.
Mm,
It's an Ayurvedic university. So they were
mm,
doing a study on, Brahmi, if that helps in improving the memory. And they had two cohorts where one cohort would be given the Brahmi Ghrita, which is they call the Brahmi is mixed with the ghee and given. And the other was probably a placebo. They said Brahmi capsules, but I think it was a placebo. And they did this kind of an assessment where they would uh, lay down a chart and place objects, different things. There was a small telephone, a doll, a cupboard, a shoe,
mm,
like that, all the daily living articles. And then they remove it. And after certain other assessments, they bring back the chart and they ask us to place all those objects in the same manner where the way it was placed earlier. So, yeah, identifying objects and then recalling those objects are similar because the GP cog also has like where you identify certain recall three words. So it's the similar thing. Like I was saying,
mm.
if we can show them pictures of animals and ask them which is this animal, and this also seems to be a good one. We can probably try it also next time.
Yeah,
Yeah.
yeah. Thank you.
So this is the mini cog, which we normally do. But then, like I said, it would be difficult in a rural area where population finds it difficult to read and write. The next slide is a GP cog. Again, it's one of the tools. Um, and yeah, so these are the index for independence in daily living. You have the bathing, dressing, toileting, moving in and out of bed, and feeding. Are they able to eat themselves? So, because these are the what I was talking about, instrumental activities of daily living, like using a telephone, cooking, uh, shopping, going to a shop by themselves, taking a vehicle by themselves, even if it is not driving, but hailing a taxi or an auto to go, uh, doing their laundries. Are they able to manage their own medications? Then finances is one thing. Are they able to handle their own finances? These are the instrumental activities of daily living. Yeah. So this is the most important thing, the clinical presentation. We have three different types of, you have the grading, the mild, moderate, and severe. So the mild one, the person might be just forgetting, uh, might say, I left my keys somewhere. I can't recollect where did I leave my keys. Difficulty in finding objects. Yeah. Then forgetting appointments. And while they are talking, they suddenly lose track of what they were talking and they jump to another topic of discussion. Then they struggle with less complicated tasks. That is the mild form. The moderate is where they find it difficult to manage their independently their living. They need help with probably shopping, cooking, forgetting what ingredient goes into what dish. Yeah. Then they struggle to learn newer things or to retain whatever they have learned new. Yeah. Then they are able to manage simple chores like, having a bath by themselves, maybe. Yeah. Going to the washroom. They can manage all that. They behave in ways that are seem unusually. At times, they can behave in a manner which is socially unacceptable also. That is the moderate one. The severe form, they are totally dependent on others for their daily living. They need help with their bathing, with cleaning, with changing their clothes, feeding. And then there is also, we find that there is loss of speech. They can speak only one word or they don't speak at all. They are very quiet. And the later stages, it is that they forget to swallow. A lot of patients, families, they tell that, they just keep it in the mouth and they don't swallow it. So they have to be reminded. So we tell them that how you remind small children, ask them, tap their cheek and say, swallow, swallow, you need to swallow. Then they swallow because they forget to swallow. They forget to eat. Or it is that they have eaten and they again ask for food. They don't remember that they have had their food. But towards the end, it is like they forget to even swallow. They have to be taught how to eat. So that is the severe form of dementia. Yeah. They can't control their bowel and bladder also. Management, we have management of dementia at three levels. We would talk about individual level, family level, and at the community level. At the individual level, here, what we do is this is more in the mild and moderate, where you manage symptoms in a non pharmacological and pharmacological manner. Non-pharmacological, it is, you have the cognitive stimulation where you indulge them in games, in activities, in conversation. It's very important because we said that the cause is isolation, loneliness. So try to involve them in your daily talk, in making decisions, make them part of the decision, of that whatever has to be taken. They might not be able to contribute much, but still It gives them a feeling that they are not forgotten. So that one. Then most important is in asking them to play certain games. We call it the mind gymming or the brain gymming, where you have the puzzles, crosswords, sudokus, all these games where it stimulates the brain. Now, in a rural area, you need to come up with something which will stimulate their brain activity. It could be, maybe what I think of is, separating the grains. Yeah. Because they are sitting at home, asking them to do something. Um, Certainly not asking them to cut vegetables because they can injure themselves. So then coloring, painting, embroidery. I think even in rural areas, this can be done. Knitting, all these activities, they kind of stimulate your brain, and also it helps with people with dementia. It helps them, people with depression. It helps them to feel better. Then functional, of course, is like doing physiotherapy, exercise, walking. It can also be that we'll come to that where community, folk dance, folk music, all this helps. Behavioral, singing, listening to music. And most important is that family should not repeat questions, even healthcare workers. Like when we go to a patient's home, we don't tell them, hello, how are you? Do you remember us? That's the first question you can ask a person with dementia. We always introduce ourselves, even if we have gone 100 times there, we still tell them, hello, sir, or hello, ma'am. I am so and so. I'm Dr. Ashoojit. I came here to see you, you know. And we don't ask them if they remember us because they might not. And that give, gives them a stress. It causes anxiety and can have anger issue, agitation, because they are unable to recollect. Do not correct because, again, it is about, oh, why are you doing this? Why are you sitting like this? Why are you lying down? Get up. So it has to be in a manner which makes them feel that they are being involved in an activity and not being corrected for something. Pharmacological, it's very limited. The disease specific, we have these anticholinesterase inhibitors like donazepam. Then you have the memantine, Admenta, which we give. These all seem to help in the memory, in slowing the progression of the dementia. So that is one. And then functional, like people with Parkinson's or even with dementia, because they don't use their limbs, they develop spasms. So we start with some muscle relaxants like baclofen. If that doesn't help, we go on to using Syndopa for them. Then behavioral issues, of course, you have aggression, agitation. So for those, we have the mood stabilizers. We can try with olanzapine, risperidone, sodium valproate. Hallucinations, we try with lorazepam because it's a short acting and immediate acting. And sometimes we need to give them haloperidol as well. Sleep issues are very important. So we give them clonazepam. We also give them, quitapine, either for sleep or even for agitation. We give them quitapine. Then they can also have tremors, which can be managed with beta blockers like propranolol, long acting can be tried, and that usually helps. So these are some of the pharmacological, very limited ones are there for the dementia. And the cholinesterase inhibitors and NMDA antagonists, that is memantine, we usually use for mild to moderate dementia. We don't use it in severe dementia. So we also need to know when to stop these drugs and when to continue, which one to continue. Like suppose there is spasm, Syndopa, we continue till the time the person is able to swallow the medications. Again, I have not spoken about end of life here, but then those are some of the things we have to know: when to withdraw, when to stop, and how do we improve their quality of life and give them the comfort to have a dignified end. The next would be at the family level. Again, it's very important. We have to keep on reinforcing the family that this is not a curable condition. It's a slowly progressive condition. It is going to progress. And we always tell them how it's going to progress. Maybe we don't tell them the severe form. If we see a patient with a mild, we prepare them from moving from mild to moderate. What could be the next steps? How the person is going to present and what we need to do as a team, that is the family and the medical team, what we need to do. Then the daily routine, it has to be like very specific for a dementia patient, that this is the time they wake up, this is their bathing time, and then this is their eating time, and then they sleep at this time. So it is very fixed so that it doesn't confuse them, it doesn't trouble them. And we also tell them to put a clock, a big clock, which is visible on the wall so that they know what is the time, and to tell them every time that this is 10 o'clock in the morning or it is 8 o'clock in the evening, it's time for your dinner, and then you have to go to bed. So we have to remind them of this. The calendar, to tell them what is the day and the date. It is important. We also ask the family to put out their family pictures, because people start forgetting even their own family members who don't live with them. So it's important to put those pictures out there and keep showing them and telling them who the person is in the picture. Then communication. It's important to tell the family that to include the person in their communication whenever they are talking at home, to include them in part of that communication. And always talk very slowly, not to rush through a conversation, because it takes time for them to understand and to grasp what you are saying. Managing behavior and mood, like we spoke about some triggers. So we have to make sure that, people don't step over them and get them agitated by triggering those points. Physical health and the basic health care. Then support for the caregivers. It's very important. We need to know that, like I said in the beginning, the person is one. We say when it is a person with dementia lives in bliss, because they don't know what's happening. And the most troublesome part or the difficult part is for the family. Family to see their person's personality change, the complete personality changes. These were the people who were their support system. And today it is the other way around, where the family becomes the support system for the person. So this is usually we find that all our family members, they tell us this, that the entire personality, my father or mother wasn't like this. They were never like this. They were always so careful about how they dress up. They were so careful about how they talk to people, how they have their meals. And now it is totally different. So the caregiver needs a lot of support. And how they need is by regular counseling, by encouraging them, by also appreciating them for what they are doing. We always, whenever we visit the family, we tell them that you are doing an excellent job. You're taking so good care of your parents, father, mother, whoever. And this is the best way to do it, what you're doing. And that gives them a lot of gratification and gives them happiness that they're doing the right thing and the right way. So it's very important to help the caregiver. They also need certain breaks. So usually it is one caregiver. So probably other family members need to pitch in so that this person, the primary caregiver, gets a break, gets a respite for a while, maybe travel somewhere or just not be the primary caregiver for a couple of days to get a break. Coming to the management at the community level, most important is awareness program. I have put it in the last, but WHO has a global action plan for dementia, that is 2017 to 2025, in which the goal the goal number 5 is about creating awareness in the community. Because unless and until there is awareness in the community, people cannot identify dementia early or intervene early to slow down the progress of dementia. So, and how we treat people with dementia to improve, to provide them that dignity. It's very important. So, I would say that, like here in Bangalore, we have certain what we call the daycare centers, because here I think there's a group called Nightingales. There's a doctor, psychiatrist, a geriatric psychiatrist, who started something called COG work. And there's now she has started something called Mind Matters, where people with cognitive decline, they could be in the mild or the moderate part or the severe one, not the severe but mild to moderate. They get together, they sit together, and they could probably just be talking anything, or they indulge in certain activities like embroidery, knitting, painting, um, even I believe sharing recipes, cooking. Yeah, these are some of the activities which are done there. So the similar kind, if we can have even in our rural areas, call it a community care center or a daycare or a rehab center, where you have certain cognitive activities like what we discussed about having puzzles or any cards, because cards also helps in improving our, uh, you know, function of the hand, holding the cards. How do we hold them? And then uh, functionals like group activities of group exercises, maybe like the folk dances, folk play, all this. The physical care can also be provided by looking into their eating, what are they eating, providing them a healthy diet, at least one meal, like we have the midday meal for the children, the similar way, if it can be planned for the people with dementia, the elderly. The caregivers community network is important because it builds a support system for those who are struggling with a similar kind of a problem. So frequent meeting and having a get together where they share experiences, they probably will tell each other how they manage, each one manages their own problems. And that helps another person to learn. The health workers, regular assessment of the patient and caregivers burnout. When do we say that the caregiver is burning out? When the caregivers become aggressive, get angry, shout at the patient, or complain of headache and body ache all the time, those are the indicators that the caregiver is having a burnout and they need a break. That's about it. That's how we manage people in the community at home with all of this. Like I said, the palliative part is that I don't think it's something different, because palliative, I feel, is more of a how do you take care of a person? It's more of a philosophy of care than actually just palliative. But palliative does means managing symptoms, but it also is a holistic approach to the whole thing. So it's not just giving medications, but this entire thing of developing um, care at individual level, family level, community level is what is required. And as the condition progresses towards the end, when the person becomes totally bedbound, not able to take care of themselves, then how do we maintain their dignity and how do we provide them comfort and improve their quality of life till the time they're alive is what is required. So when do we stop the medications? When is it not required? When is it doing more harm than good? Is all the decisions we need to take as doctors. Thank you. Thanks, Shyam.
Yeah. Thank you for the session, Dr. Ashoojit. We are now open for questions. One question I wanted to go with, these drugs like donepezil and the other one which helps with the memory. Do they make yeah? So do they make a major difference? Like because I think the cost is also high.
Yeah.
So in
Yeah,
mild moderate,
cost is high. Yeah. When it is mild dementia, it does help. So it helps in delaying the progress of the condition, because, the cholinesterase inhibitor, what it does is, it allows the cholinesterase to accumulate there and help in the transmission of nerve impulses. So it does help. But if it has progressed to an extent that you don't find that this is having any improvement, you can try it. It's not that you have to continue it. You try it for a couple of months and see if it's making a difference, if it's really delaying the progress, probably improving the memory, then you can continue. Otherwise, you can stop it.
Okay. Yeah. I think Vasu had a question in the chat. Vasu, you wanted about something about mild and moderate. How do you, yeah, in mild and moderate, is there any number like which by which you can fulfill that if there is this much number of symptoms, then you call it mild, or if this is there, then you call it moderate?
There's no number of symptoms. It is mild is where it is just forgetfulness. I I can't remember where I kept my things or forgetting appointments. We had a patient who started with this kind of forgetfulness of, keeping, I wrote something, but I don't know where I kept my diary, forget appointments, or he would land up at the place where he has to, and he would wonder why did he come there, and he was one of the directors of some big company. But when he would go for a meeting, he reaches there and then he would wonder as to why did he come there. He would forget that he has a meeting. So again, this is mild because it's not interfering with his so much of his daily living. Once he's reminded that he has a meeting, he would reach there. Right? Or he keeps a reminder. Sorry. But when it starts interfering with your daily living, You're forgetting if you have eaten your food. You're forgetting that you had a bath or not. Yeah? Then it is the moderate type where you are unable to do your cooking. That means you forget as to what you need to add, what spices, or they put on the gas and forget to close the gas. Yeah. So things get burnt. That is the moderate one. So it's like the mild one is not interfering too much with your daily living.
Hi, can you hear me?
Yes.
Hi, Ashoojit. Thanks for this. Sorry, I couldn't attend the whole thing. I was having trouble joining and leaving and rejoining. So, supposing in the moderate one, struggles to learn or retain new information, which also depends on complexity, aptitude, and so many other things.
Yeah.
Now, can we look at just one thing and say, oh, this is moderate dementia, or it has to be like multiple things that make one feel that this person is behaving in a certain way, or something is not right.
Yeah.
That's why I asked
It has
whether
yeah,
fulfill
yeah.
criteria, or one has to look at multiple things, and whether it is really important to classify. I mean, or there could be gray areas between mild and moderate, and whether one should intervene at the mild stage to prevent progress, or it is going to progress anyway. Yeah. So one is intervention at mild or mild to moderate, and whether there are overlaps between mild moderate. Thanks.
Yeah, that's right, Vasu. So as coming to intervention, mild or moderate, intervention is a must. Yeah, because definitely, like I said in the beginning itself, that it's a progressive disorder. It is going to progress, whether you intervene or you don't intervene. But it is just that it is delaying the progress by intervening, by doing all of those where we indulge them in some activities, brain gymming. All this is going to delay the progress of the condition. So, longer they are in the mild or the moderate level, it's much easier to manage for the family and for the person also. Because the person also, initially when they are forgetting, they are actually quite distressed because they are not able to remember. I keep forgetting things. I keep forgetting names. I'm forgetting, I don't, when I see your face, I don't remember who this person is. It's quite distressing. So, any kind of intervention delays the progress of the condition, which is good. We don't want the progress to be fast, but we cannot arrest it. No medication, no kind of activity can arrest the progress of the condition. Yeah.
Okay. Yeah.
And it is not one thing where we can say, suppose somebody is not able to remember the ingredients for cooking and we say it is moderate. No. Again, like you said, yeah, we look at, are there other things also indicating that there is dementia? Then you use those tools, do a mini cog or a MMSC or whichever tool, GP cog, and see if the person has dementia. Yeah.
Okay. One last question I had, like, is you mentioned that with age also that cognitive level will decline, cognitive performance. So, and in dementia also that be a decline. So, when can we say that this is dementia and this is physiological age-related decline?
And physiological age related will not progress. There might be just some forgetfulness. I forget the face of the person when somebody came and said hello. It took me time to remember the name. Yeah.
Mm-hmm.
And then I could recollect.
Okay.
When somebody introduced themselves, I could recollect.
Yeah.
So
Okay.
that is age related. But when it is progressing, they are not able to recall, then it is dementia. It's not age related.
Okay. Yeah. Any other comments or questions? Anybody else?
Not really. A difficult subject made to look reasonably easy. And your experience really mattered, I know. And I was thinking of asking the same question as Sham asked. See, sometimes it becomes very tough to differentiate between what is normal and what is abnormal.
Aging.
And people who aging forgetfulness, they recall maybe 2 minutes or maybe 20 hours, but they will be able to recall. But then the dementics, they find it almost impossible. The distressing part is they know. That means that face they know, but they are not able to place where and how and what, and that causes distress. Anyway, thank you. Well presented.
Thank you. Thank you, sir.
Dr. Milind Bharti is requesting to share the PPT in the chat.
Yeah, please go ahead.
Okay. Okay. So I think if yeah. So Vasu, you want to ask anything? You are posting something in the group.
Yeah.
In the chat. Yeah.
So now my parents are 87 and 91. My father forgets a lot. He forgets to turn off the gas and the light or the water tap almost every day, or leave the door open and all. But otherwise, he's pretty okay. And and he's not diabetic or hypertensive. So it's difficult to tell whether it is age related or it is some progressive form of dementia, because this was not there maybe 5 years back. Okay, my mom occasionally forgets, but again, it was not there some years back. I've also become very forgetful, but that I think from childhood there were some issues.
You're bluffing.
But conveniently
Yeah, Vasu, you're a liar.
No, I recognize your voice. You are Dr. B.C. Rao. But now I remember. But I certainly feel that I've become forget some things, names, and I cannot recollect incidents. But I don't know what that is. But I conveniently blame it on COVID. But for them, I can't say whether I should do something about, especially my dad, because it's leaving gas on, leaving a door open, not locking it. Those should I be doing something about it or not? Like difficult for me to.
You don't need to start them on any medication or anything. Just see if there are any other things which are developing, just one or two things which have been happening. It can be just forgetfulness because of, like we say, aging, So just forgetting a little bit is fine. Yeah. Like forgetting to close the tap or locking the door is okay. But if it is progressing, then maybe you can conduct a mini cog or a GP cog would be much better. It's more extensive for you to understand if there is really for dementia setting in. But otherwise, not required.
And plus, I believe that all the senses are pretty much interlinked, no? Hearing, seeing, then
like I said, ask them what did they watch. Yeah. And ask them to tell you what was the news. You should randomly ask, not like you're checking their memory.
Yeah, so some of the topics which he likes or he's engaged in, he'll tell that, no? But not everything. Plus, he's almost has only 20% hearing, and he won't wear his hearing aid also. So he's
Yeah.
blissfully in that state. And
Yeah.
then,
So people who have hearing problem
yeah,
are known to have dementia later because they kind of, get isolated. They
yeah,
can't hear, they can't communicate.
hmm,
So that causes dementia because there's no information which is
yeah.
coming to them.
So that's what. So I feel that also plays a part.
Yeah.
And sleep
Sham
deprivation.
Sham wants to ask something. Yes, Sham.
It's not Shyam. The participant has changed. This is this is not on a lighter note. He's not here, but yeah, he has to catch the bus. But I wanted to ask one thing, which is I feel it's a bit concerning me. Shyam forgets names, like names like when he was talking to someone, he said, I forgot the name. Who is presenting today? I forgot her name, but she's presenting. I had to tell her that Dr. Ashoojit is presenting. It doesn't mean that it doesn't remember that your presentation is there, but he randomly forgets the name of people. Like somebody comes and visit us, then he would say, I forget his or her name. So this happens very much frequently with him nowadays. Is it something which we should concern about, or I don't know.
It could also be just stress related. Yeah. Because the kind of work which is he's doing all by himself, that also could be causing stress. Uh,
Hmm.
look at look at his sleep. How is it? Yeah, and stress levels. Assess that. Yeah, and maybe that could be the reason. Nothing to really worry about dementia at this age. I think Shyam is still quite young to worry about dementia. But yeah, so stress, de-stressing is very important. That's why actually when I spoke to you last week also, Apeksha, I asked you what about breaks? Breaks and then only working on your publications and writing and all is not a break. Yeah. You really need to take a break where you are mentally away from doing these activities. Yeah. So that could also be the stress could be causing that.
If anybody have any question, then we can take it, or else we can conclude the session, I guess.
Yeah, I think. Also, you have anything more?
No, Ashwini, thanks.
Okay.
This idea just came suddenly that, if there is a shared drive, where, like if BHS, if Ashoojit or TRU or uh, Dams or Sachin from um, Chakradharpur, Ekjut, or Nilesh, who are working in rural areas or have ideas, could not just uh, PPTs, but populate that thing saying actually, like, what has worked and what has not worked. If you think of family intervention, if you think of patient support groups, or think of medicine, uh, so, and actually mentioning the activities that work, both psychological, psychiatric, what are the assessment tools that work, that it would be nice to have something
I
like a
will. Yeah.
repository, like, if
Yeah,
people are willing.
yeah, I'm sure that will be really good. Yeah.
Mhm. Can think about it. Yeah. Okay.
Yeah, sure. So there's Milind who has raised a hand. Yeah, please go ahead.
Thank you, ma'am, for this wonderful presentation, and really very sweet and short, enlightening us. Just briefly, I would like to have your valuable opinion, association of metabolic disorders with dementia progression. How you can just relate these two entities. I mean, like how we can like identify early if somebody is having other conditions. So would you please enlighten us with a few important words we can relate to that?
So, metabolic disorders like, diabetes or anything, this causes a lot of inflammation, right? We all know that. Inflammation in the blood vessels, which causes, atherosclerosis or thrombosis, which causes, again, lack of less blood supply. So it becomes like um, a vascular cause where there is less blood supply to the brain, that thereby leading to dementia.
So is there like a intervention is important at early stage or later? How would you
Absolutely,
suggest it?
absolutely. As early as possible. That's why it's very important to indulge in, learning. They say that anybody and everybody every year should learn one skill, one new skill. So, like maybe learn a language, a different language, and or any other different skill. Developing that helps in delaying onset or delaying or not having the dementia later.
Awesome, great. Thank you so much, ma'am. Thank you so much.
Yeah, I think we are done. If
Yeah,
Shyam
I
is
think we
back
are
or
done. We can
Aveksha, we can.
conclude. I think we
Yeah,
can
we'll,
conclude the session.
yeah.
Yeah.
Thank you.
Thank
Thank
you.
you,
Thank you,
Aveksha.
Dr.
Thanks,
Ashoojit.
Shyam.
Yeah. Yeah.
Thank you.
Yeah.
Thanks, everyone,
Bye.
for being part of this. Thanks.